Our first speaker is Dr. Michael Grandner, and he joins us today as a licensed clinical psychologist and board certified doctor in behavioral sleep medicine. He is the director of the Sleep and Health Research Program at the University of Arizona and the director of behavioral sleep medicine program at the Banner University Medical Center in Tucson. Dr. Grandner is associate professor of psychiatry, psychology, medicine, nutritional sciences, and clinical translational science at the University of Arizona. He is an internationally recognized expert in sleep health and has over 150 academic publications and frequently consults with health, technology, athletics, and nutritional companies and organizations regarding sleep health and performance. To find out more about him, go to michaelgrandner.com. Welcome, Dr. Grandner.
Hi, and I'm really glad to be here and to talk about this issue. So, all right, so let me share my screen with some slides. I'm going to turn off my video for bandwidth, but I'll come back for Q&A. And so I'm going to be talking about navigating narcolepsy and mental health. First, a couple of disclosures. I have received grants from a couple of industry partners, and I've done some consulting, but none of that has anything to do with anything I'm talking about, but I just want to let you know that that exists. So I'm going to be talking about mental health, and this can sometimes be a difficult thing to talk about. But I think it's important that we have this tough conversation. Mental health is a public health problem. So here's some US-based statistics. The suicide rate in the US has risen by 33% since 1999. More than half of Americans will get a mental health diagnosis in their life. 1 in 5 experienced a mental illness in 2019. The annual prevalence of a major depressive episode is 1 in 11 people. The annual prevalence for anxiety disorders is about 1 in 5 people. Less than half of people with mental illness actually received treatment in 2019. And mental illness is involved in 1 out of 8 emergency room visits. For anyone who is struggling with mental illness and is worried or has a friend or family member, that there are a lot of resources. These are all US-based resources. They're easily Googleable. You don't have to write down all of these links, but SAMHSA, NIMH, and NAMI are all excellent organizations with lists of resources and helplines and other things. Rather than put each one on there, I just figured I'd put the links to these collated lists. Also, mentalhealth.gov is a resource a lot of people don't know about that also collates a lot of these. And there's also the Suicide Prevention Lifeline, which is nationwide. A little bit about sleep and mental illness in general. So sleep disturbances are described as a core feature of pretty much every single diagnosis on the spectrum of mental illnesses, whether it's depression or bipolar disorder, anxiety disorders, including PTSD for post-traumatic stress disorder, major mental illnesses such as schizophrenia, attention deficit disorders, and more. Pretty much every diagnosis has a component of sleep disturbance in there. And it's not just that mental health problems cause sleep disturbances, but it also goes the other way too. The relationship between insomnia and depression is one of the most well-established findings in all of sleep research. And poor sleep quality in general is associated with every single symptom of depression. So here's some data we published relatively recently, where we looked at every item on the PHQ-9 depression scale, whether it was looking at anhedonia, which is inability to enjoy things and feel pleasure in things, whether it's depressed mood, there's the sleep disturbances and daytime tiredness, appetite symptoms, feelings of failure, difficulty concentrating, psychomotor symptoms, and even suicide ideation were associated with difficulty sleeping and or difficulty with daytime disturbances due to poor sleep problems like daytime sleepiness. And also the perception symptoms. These were the symptoms of sleep problems where I'm not satisfied with my sleep, something's wrong with my sleep, I'm worried about my sleep. Those things are independently associated with all of these different aspects of depression. And I put this slide up here. This is about insomnia and short sleep duration, not necessarily narcolepsy, but I think it tells an important story, and that the contribution of sleep problems to, say, depression is complicated. And what it means is that insomnia itself, so what this study showed was insomnia itself is associated with higher depression risk. And you can see that by all these diagonal lines angle and point upwards, which means the higher your insomnia severity, the worse your depression score is as well. But the lines are different. And what it shows is that green line is the short sleepers. These are people who also aren't getting enough sleep. And you can see that the line that links insomnia and depression actually is not as strong in short sleepers. That's because short sleep itself confers its own risk and takes and eats up some of the risk from insomnia. So what this is saying is that combinations of multiple sleep problems can be worse than either one alone, and it changes the relationships with them. And in the case of narcolepsy, you usually have a combination of different types of sleep problems. And it just goes to show that that combination itself is something to be on the lookout for. And I want to talk a little bit about suicide risk because it's an important mental health issue, but also this is something we've done some work on in our group that I want to talk about, these links between poor sleep and suicide risk. So a suicide occurs in the US about every 12 minutes on average. The suicide rate has risen, as I mentioned. Suicide is the second leading cause of death for all ages 10 to 34. And I want to take a second on this one. A lot of people don't realize how big of a deal this is. It's still the fourth leading cause of death, ages 35 to 44. So it's a major public health problem. If there was a disease that was the second leading cause of death for ages 10 to 34 and the fourth leading cause of death for ages 35 to 44, we would be searching for a vaccine for it. We would be devoting our resources to try and solve this problem. This would be an emergency. That's where suicide is right now. 1 in 5 US adults has serious thoughts of suicide each year. And it's the leading cause of death in military service members. A bunch of years ago, less than 10 years ago or so, it eclipsed warfighting. It eclipsed active duty and being in dangerous situations for service members as leading cause of death. It's also rising faster among women than men, even though most suicides are men. Insomnia itself has been studied as a risk factor for suicide. There's a study by Will Pigeon and colleagues who basically they took all of the literature that was out there at the time, pooled it all together into a meta-analysis, and essentially showed that insomnia triples likelihood of suicide. It triples the likelihood of suicide ideation. This is thinking about it. But you got to remember, most thoughts of suicide don't end in attempts. There's a big gap, but it also triples the likelihood of attempts. And many attempts are unsuccessful, but it also more than doubles your likelihood of actually death by suicide. So it's parallel. It just doesn't just lead to suicidal thoughts. It also is associated with the behaviors. And that's really, really important because most suicide risk factors can lead to thoughts, but they don't seem to lead to some of the other things as well. Medications can sometimes be problematic. So here's a study that we recently published looking at 2 big, large national data sets. One, they were able to look at Z drugs. This is mostly Ambien and Lunesta, but others would fit in there too. And benzodiazepines for usually given for sleep, but also anxiety. Looking at their impact on suicide ideation, but also planning and also attempts. And what you can see is even after adjusting for age and sex and race, ethnicity, and socioeconomics, we see a strong relationship between use of these medications and all of these different aspects of suicide. And even after we control for things like depressed mood and all of those other things, you still see a significantly increased risk. But then when we looked at NHANES, which was another national data set, we saw, again, you see this huge increased risk of, they only measured suicide ideation, but you can see this big increased risk with Z drugs and trazodone. So that might be surprising because trazodone is supposed to be an antidepressant. The way I interpret these data is not that these sleeping medications cause suicide ideation and suicide risk, but probably that they're a marker that people who are not sleeping well and are seeking help for sleep have increased suicide risk no matter what medication they're taking, and that medication doesn't seem to be fixing that problem. So I think that that's the message here, not that the medications themselves are probably causing all the problems. It's more likely that it's about the sleep problem. Sleep disturbance itself, so this is something that lots of narcolepsy patients struggle with, but basic sleep disturbance, where your sleep is in general disturbed, whether or not it's insomnia, you could see that the more that you have sleep disturbance, the longer that sleep disturbance goes on, the more likely you are to be at risk for suicide. So this is some data we looked at in terms of sleep disturbance in young adults, showing that different types of sleep disturbance double or triple or quadruple your likelihood of thinking about suicide, even after adjusting for depressed mood. So it's not just about depression either. And then we looked at how many nights a week you weren't getting enough sleep. And we showed that for each night per week that you weren't getting enough sleep, your likelihood of thinking about suicide goes up, again, even after controlling for depressed mood. So there's something about not being able to sleep that seems to be driving this. So the question was why? And so we had a hypothesis that actually it doesn't matter what caused the sleep disturbance, whether it was insomnia or some other sleep disorder or what, but simply being awake and struggling with sleep when your body wants to be asleep was a problem. So what we ended up hypothesizing was, well, in that case, more suicides should occur in the middle of the night. And so what we found was, when we looked in the literature, was actually that wasn't the case. So you can see here that the suicides are peaking during the day and they're lowest during the night. So here's another study that showed the same thing. They're peaking sort of in the morning and then lowest during the night. So here's another study out of Italy that showed a similar thing, where they're lowest here at night and they're peaking during the day. So we're like, okay, well, maybe that's incorrect. But actually, we think that this perspective, that this way of looking at the data was actually wrong. And there actually is a potential looking at suicide during the night. And this is what we found. When we filtered out the wakefulness signal and looked for we filtered out the wakefulness signal to look just at the suicide signal, we actually found the opposite. This is data from 10 years of CDC data of every suicide across 19 states in the US. And we looked at when they happened. When we filtered out the proportion of the population that's awake at each hour, we actually see the spike in the middle of the night in men and in women around 2, 3 in the morning. That's when the suicide risk is the highest in the US. And when we looked, it cut across every group, cut across every age group. And here you could see across every race ethnicity group. This is a marker of how strong the effect is. So this would be a low effect. This would be about a medium effect. This would be a strong effect. And sort of in every group, you see it as a strong effect of being awake in the middle of the night is a risk factor. We also look to see, does it vary by time of year and season and month? These are the lines for suicides that occur in the afternoon, the evening, in the morning. This is the increased likelihood of suicides occurring at night. Again, it's higher and it cuts across the year. Then we looked at methods. Is it leading to one particular method of suicide or other? This is, the other times of day. Here's the elevated risk of these things occurring at night. Again, they're all higher and they weren't statistically significantly different from each other. It is important to note that firearm-related suicides are the vast majority of suicides in the US, where we've actually begun replicating this data in other countries that have different gun control laws, showing that even without these firearm-related deaths, you still see the same increased risk at night. So then we asked the question, well, because we filtered out the proportion of the population awake at night, we didn't know that there were these people in particular who were up at night versus not up at night. So here we looked at a data set where we tracked who is awake at different times of day and are they people who've thought about suicide. And what we could see is the people in gray without the suicidal ideation, they were more likely to be awake here in the morning, and they were actually less likely to be awake during the night. And the people who had thought about suicide were more likely to be awake during the night and less likely during the morning. When we normalize this across a scale, you could see the likelihood of suicide ideation goes up when you're awake at midnight and 1 a.m. And it goes down if you're awake at like 5, 6, 7 in the morning. So the people who wake up early were much less likely. But then we thought, well, this was a sample we found. There's no broad generalizable data about the population, but the NHANES actually recently released some nationally representative data on time in and out of bed. We looked at weekdays and weekends, same thing. People who nationally representative, these aren't depressed people, these aren't sleep disorders people, these are just people in the population. When they're awake during the night, they're much more likely to be thinking about suicide, especially if they're awake in the night during the week. And if they're awake in the morning, they were less likely at 5, 6, 7 in the morning. On weekends, the 5 a.m. effect wasn't really there, but it's more like 6, 7, 8 o'clock in the morning. So what about narcolepsy? So I've talked about a whole bunch of other stuff. So there's still very little scientific work looking at links between narcolepsy and mental health. There's some, and I'm going to summarize sort of what I found. But this is despite countless patient reports that narcolepsy is significantly impacting mental well-being in many ways. One of these ways is the stigma of narcolepsy. So here's a study here that actually looked at the role of stigma in depression and daytime functioning. And actually they showed that the perceived stigma of narcolepsy and daytime sleepiness was actually a major driver, in addition to the sleepiness itself, of poor daytime functioning. There's also a couple dozen studies now showing that difficulties with daytime functioning impact health-related quality of life. So so there are over 30 studies that have looked at this in narcolepsy. And generally the take-home message is, yes, people with narcolepsy have reduced quality of life. So here's one relatively recent study that I found showing that for men, people with narcolepsy report about 82% higher scores for body pain, about 38% worse scores for social functioning, and about 20% worse scores for general overall health. And women, it was pretty similar, where they had more than 50% worse scores for body pain, about 45% worse scores for social functioning, and about 25% worse scores for general health. They also had about 10% worse vitality scores. So in terms of just how this thing impacts your daytime functioning, it takes a toll, and it adds stress and makes things more difficult. One of the reasons why might just be because of some of these overlaps. So here's a lot of things that occur in depression. So in depression, you get debilitating fatigue and lack of energy. In narcolepsy, you get severe excessive daytime sleepiness. In depression, you get disturbed sleep and difficulty maintaining sleep. In narcolepsy, you also get disturbed sleep and fragmented sleep. In depression, you get delusional beliefs where your reality testing actually becomes problematic, and people don't often think about depression as sort of a reality testing and ability to perceive the world correctly, but people who are depressed believe that everyone hates them, that they're a terrible person, that everything is their fault, all these sorts of things, which are not rationally true. So depressed people have very delusional beliefs. Well, narcolepsy patients have hallucinations as well. They get sleep-related hallucinations where if you don't know what these are, they can be very distressing and feel like you're not sure, you have difficulty with reality testing. In depression, they get a lot of psychomotor problems, whether it's agitation or more likely psychomotor slowing, where they become slowed, they have a hard time moving, and often people with depression, they'll say that they lay down and they just can't get up and they just can't move. They just can't get themselves to get moving. Well, you get cataplexy and sleep paralysis in narcolepsy too. People with depression have profound problems with work and school performance. So do people with narcolepsy. People with depression can feel very isolated and withdrawn from others. People with narcolepsy have a lot of isolation and difficulty socializing with other people. Depression causes appetite disruption, especially weight gain and loss. Well, narcolepsy also can be associated with weight gain. Depression has a lot of feelings of hopelessness. So does narcolepsy. Unless you're adequately treated and under control, you can feel very out of control and feel like that things might not get better, and because you have this thing that's not under your control. Depression comes with a lot of feelings of guilt, but so does narcolepsy sometimes. Depression has a lot of perceived laziness. So does narcolepsy sometimes, especially people who are carrying around a lot of excessive daytime sleepiness that can often get interpreted as laziness. So you can see here that there's a lot of reasons why it makes sense that a lot of mental health problems are overlapping with narcolepsy, because the problems that people with narcolepsy face are the same kind of problems that people with mental illness face, and they could be driving a lot of these things. So here's a study that was done almost 10 years ago now, looking at the rates of mental illness in narcolepsy patients versus people who are not narcolepsy patients. And what you can see here is pretty much across the board, people with narcolepsy are more likely to also have a wide range of other mental illnesses. It just is a risk factor. You know, they're twice as likely to have ADHD, social anxiety, PTSD. They're more than twice as likely to have depression. They're more than 3 times as likely to have an anxiety disorder or an obsessive compulsive disorder, or a panic attacks. And they're more than 4 times as likely to have phobias or bipolar. But the one that really jumps out to me is agoraphobia, where they're more than 6 times as likely to experience agoraphobia. So for people who don't know, agoraphobia is sort of a fear of leaving the house. It's a fear of going out. It's a fear of being in a situation where you're not safe and contained. It's sort of the opposite of claustrophobia, where people who are claustrophobic have a fear of being sort of trapped and being unable to escape and things. Agoraphobia is the opposite. It's like, you know, if you leave the house, bad things are going to happen. And that makes sense, especially people with narcolepsy who are undertreated and who have these attacks that they feel like they can't control when they're out in public. So I think this is something that's not talked about enough. All of these things, by the way, are treatable as mental illnesses. Just a lot of times people with narcolepsy see it as either part of their disorder, or they don't know what to do or how to get help. Remember, less than half of the people with mental illnesses got help for those mental illnesses in 2019. Another important overlap here is the overlap in medications. If you look at the medications then that are being given for narcolepsy, a lot of them are overlapping with the same medications that are being given for other mental illnesses as well, depending on the symptoms that people are facing. So there's a lot of biological reasons for potential overlap. So we already know that sleep is tied to mental illness in general, and narcolepsy in particular might put people at elevated risk for more mental health problems because of the disorder itself biologically, but also just because of the impacts that it has on people's lives. And what I want to talk about is the wider context. So this is a picture that sort of puts sleep in the context of where this all fits together. So you have sleep health here. Downstream of sleep health, you have metabolic health, cardiovascular health, immunologic health, mental health, behavioral health, and cognitive health. All 3 on the left, sort of bodily, and the 3 on the right, sort of more brain related, but they're all sort of intertwined with each other. And mental health is a key part of this ecosystem of health that is in the context of all these other domains of health. And when you have a sleep disorder, all of these things can be impacted because sleep plays a role in all of them. But it's important to understand the context. So if sleep health is important, what is upstream of sleep health? You know, we have these individual level factors. We have, you know, and especially in narcolepsy, we talk about this a lot, things like genetics, things like your biology, but also things like your own attitudes and beliefs and decisions. These are all things that exist inside of you. If you cease to exist, they would cease to exist. And a lot of times when we're talking about the relationship between narcolepsy and sleep health and these downstream health outcomes, this is sort of where the conversation ends. But I would argue that this is just where it needs to begin. I think next we need to talk about the social level. You're embedded within a social level. These are things that it's not a separate circle. We're part of that circle. These are things that if you cease to exist, they would still be there though. Things like your occupation, your school, your family, your neighborhood, your social networks, your religion, your culture, all of these things that you're a part of, that your individual biology, behavior, psychology, health, all of these things are embedded within. and they're important drivers. And if we're going to understand the context of narcolepsy and mental health, we have to appreciate that these individual level biological and behavioral factors exist in a social context. And if we ignore that social context, we miss a big part of the picture, especially when it comes to mental health. And even still, the social level is embedded within a societal level. These are things like globalization and 24/7 society and discrimination and racism and public policy and all of these sorts of things that drive our social networks and our jobs and our families, that drive our individual behaviors and biology and exposures. So I think this is the picture that we need to keep in mind, because if we're going to make a difference for mental health, we have to understand the context of mental health with other domains of health. It's not totally separate. They're all in it together. And sleep being upstream is important to know. But if we're going to benefit sleep, if we're going to understand the importance of sleep and the role of sleep, we have to understand this embedded system of the individual within the social, within the societal. And I'm pretty sure everybody on this webinar or watching can think about ways in which it wasn't just their biology that influenced their behavior. It was also their obligations and these social networks that play an important role in how they experience things. So I wanted to spend some time on this because I want to challenge people to think of it in this way, to think of this embedded system as the driver for sleep, so that you're not alone, that just because you can't change your biology doesn't mean you can't make some sort of other changes, and also that just because you can change your biology doesn't mean you can't. You can also change all these social and other structural issues, that they all work together. And so that's why I wanted to leave this on for a little bit. One aspect of this that I just wanted to end with is the idea of control and autonomy. So this is something that our group has been working on a little bit, where my hypothesis is that a big factor that links all these things together is control over sleep. When you ask people how they sleep and they say not great, it's usually not because they hate sleep. It's because they want to sleep better, but they often can't and they struggle to. And the reason is that they don't have control. So we sort of developed this brief screener for sleep control of how much control do you have over when you go to bed and when you wake up, and how much you sleep and how well you sleep, and we correlated that with other aspects of sleep, and we showed pretty consistently that people who don't have control have worse sleep quality, have more insomnia symptoms, don't sleep as much, and importantly also have a lot more daytime sleepiness. And I think that if we can maybe help improve people's sense of control over their sleep, we can improve their experience of sleep health and daytime functions. This is the brief index of sleep control. But just this idea of control. And in narcolepsy, you get a lot of this lack of control. And then in treatment, you potentially increase your sense of control, even if you can't prevent sleep attacks from happening, or you can't prevent some of the sleep fragmentation. You can start gaining some control over it so it doesn't rule your life. And I would argue, and I guess the reason I put the slide in here, I would argue that that sense of control is in and of itself an important goal. That even if you can't fix all the problems, at least you can gain some sense of ownership and control over it, where you can help integrate it into your life a little more. So that's what I wanted to talk about. A quick plug for our lab. Here's our lab website and all of our students and some of our funding support. And here's my contact information. If you ever want to get a hold of me, here's my email. Follow me on Twitter. And I really appreciate your guys' attention, and I'm here to address any questions I can. I'm not necessarily a narcolepsy expert, but I do work with patients, and as a psychologist, I could answer and also any mental health and sleep questions that you have.
Thank you, Dr. Grandner. That was amazing. Thank you so much. And we do actually have a question. Yeah, that was very powerful, especially when you just see the visual kind of facts that maybe some of us are aware of, but just not, as good as articulating it as you. So that's very validating. Thank you for that. Now I have a question. I'm going to read it to you.
Sure.
In the Q&A, and if any of you do have questions, rather than pop it in the chat where we're kind of answering to each other. If you put it in the Q&A, then I can direct them straightly to Dr. Grandner. So first question, how can I bring this information to my therapist who doesn't have other patients or experience with narcolepsy? My depression has gotten worse since my narcolepsy diagnosis, and I felt like my medication wasn't helping as much.
Yeah, I would say, I mean, that's a tough thing because a lot of, especially sleep medicine physicians, don't get a lot of training in mental health. I mean, most physicians don't get a lot of training in mental health. I'm fortunate that I get to work with a sleep disorder center where we refer patients back and forth. And when they see somebody, they know who to send it to, but a lot of people don't know who to send people to. So I guess the first thing I would say to that is, first recognize that your physician may not know what to do. They may not even know what questions to ask you to understand a mental health issue. So what I would suggest is, if you're based in the US, actually even internationally too, though there's less, you might want to go to the Society of Behavioral Sleep Medicine. It's mostly made up by psychologists and other mental health practitioners who deal with sleep stuff. And there's a find a provider on there too. You could ask them for referrals to a mental health provider, where the mental health provider probably has no idea what narcolepsy is, to be totally honest. They probably have little to no idea, but they know how to identify and treat depression. And the literature shows with depression, it's a very tricky thing to treat. A lot of mental illnesses can be very slippery, where when you go at it from one direction, it hides somewhere else. And so sometimes a single approach is not enough. At least in my experience, dealing with a lot of patients with depression and anxiety, especially when it's complicated with other health issues, you have to go at it from multiple angles at once. So one medication might be enough, but often it's not. So find a psychologist, find a therapist who can work with the medication. You might need to tweak medications as well. And in terms of an approach, there's lots of approaches to treating depression. Sometimes some of them are more behavioral. You can look up something like behavioral activation or something called CBAST. There's also CBT for depression, which is probably the most well-known, but people do it in lots of different ways. But there's also cognitive therapies for depression. There's all kinds of other things that people can do. Maybe another thing I would recommend is look for someone who calls themselves a health psychologist. So it's sort of a field within psychology that's focused on the intersection of psychology with other domains of health and medical problems. So they'll look at how medical conditions and pain and other things impact mental health. So that might be a really good resource. And if your sleep doc doesn't know who to refer to, look at the community, see who's covered under your insurance, but it might take more than just that. It might take more than just a single provider and a single prescription. But the other thing I do want to say is depression is hard to treat, but highly treatable if you get aggressive about it. If you take it from a perspective that you just need to find the right therapist, find the right combination, it might take some trial and error. Outcomes are good for people who do that.
Thank you. The next question is, do you, Dr. Grandner, have any bullet point style resources that we can provide our medical doctors and cognitive therapists to help them understand narcolepsy?
That's a great question. I mean, I'm sure that Wake Up Narcolepsy and some of these other organizations have some great handouts that are probably better than anything I could put together. But and any of these slides are available. There are some good resources out there, and I think you hit on the important point that sometimes it's up to the patient to educate the clinician in something that they just don't have experience with. And that's okay. They know lots about lots of other things. And with that one piece of that one extra piece of knowledge can help integrate into the wider bits that they know. But yeah, sometimes it's up to patients to educate the clinicians. But my guess is, and Claire, you can let me know. My guess is that the organization probably has some good resources or knows where to find some, probably better than I even do.
Yeah, I think a good point would be to email us at info@wakeupnarcolepsy.org and we can take it from there. This is certainly kind of another area of growth that we're seeing a lot of people have these questions, and they're having to self-advocate in the
Yeah.
doctor's office and say,
Yeah.
this is what narcolepsy is. And it is very frustrating for the patient, but that is where we are kind of at in the sort of the health space. So yeah, give us an email, send us an email, and we'll see if we can provide some information on that. Okay, so another question. Would you suggest the lumbar test or the genetic blood work to see what medications work with your biochemical system?
The science on that is, I wouldn't, only because I don't think the science is ready to give me information that I trust enough to make a good decision yet. There may be some data out there, and if you're working with someone who has a lot of experience with that, maybe, but my understanding of the science is it's we're at the beginning of it. We're not at a point where it's really reliable yet. Unfortunately, there's just lots of trial and error. There's some stuff you may find out, like if you have an issue with norepinephrine, for example, you might want to push to or avoid an antidepressant that has norepi in it, whether it's like an Effexor or a bupropion or something. But I don't know that we're there yet, to be totally honest. I think the ideas are there and it's starting, but maybe 10 years from now, we'll look back and say, yeah, 10 years ago, we were just starting to figure this out, and now we know.
Yeah, it's another area of growth, isn't it? It's accelerating at a fast pace.
I wish it was there. Like because we see it just over the horizon, I think. And I think collectively, societally, I think we see this potential, especially narcolepsy patients who've seen the role of genetic testing and the promise of it in a way that other disorders haven't quite yet been able to see. Because I think narcolepsy patients inherently understand how valuable it could be, but I don't think we're there with mental health yet.
Yeah, perhaps some of that is because of the overlap, as you said, with depression.
Mm-hmm.
It was so striking, the kind of that slide with all the similarities. It's like, it's very hard then, isn't it, for doctors to know what is narcolepsy, what is depression, and that's why so many people are misdiagnosed
Exactly
with depression. So that's very helpful. I think we have time for one or two
Sure.
more.
Sure, I'm here.
Okay, thank you. Can you give any information on disruptive and not good / not enough sleep in relation to causing hallucinations, audible or visual? I've heard it described as dreams coming through because your body doesn't know if it's awake or asleep. And then I know that a lack of sleep makes your body act weird.
Yeah. So you have the sleep related hallucinations and sleep paralysis, which, though I think that's a good explanation of it. The way I say it to patients is that, when you're getting REM related brain phenomena leaking out of REM, where these are supposed to occur only in REM sleep when you're not really conscious, so it's fine. But what's happening is REM sleep and wakefulness are bleeding together. And the boundary between them is getting thin, and so you get things that are only supposed to occur in REM sleep happening in wakefulness, and the brain doesn't really know what to do with that information. It's trying to make sense of this, and so then you create these. You make sense of it by creating these experiences, and in narcolepsy, I think that's why you get that more common, because narcolepsy is all about, right? It's all about the boundaries between these states that are supposed to be drawn with a thick black marker, sort of getting smudged and erased a little bit. And so, one way to maybe wrap your head around it is, because the boundary between REM and wake and non-REM sleep are blurry, you're getting elements of one leaking into the other, but that's all it is. That's what it is. I don't need to make it into more of that or less than that. It's the same thing as feeling like sleepiness is invading wakefulness. This is REM invading wakefulness, kind of a thing. What was the other part of the question? I forgot. I got sidetracked.
Yeah, that's good. It's the last piece was, I've heard it described as dreams coming through your body.
Yeah.
You don't know if it's awake or asleep.
And what was the first part?
Can you give any information on disruptive and not good?
Oh yeah. So can that be made worse by disrupted sleep? I mean, clinically, we see this all the time. I don't know that there's a lot of data. We looked at it a little bit and showed that when sleep is and other people have done this even more, showing that when you especially disrupt sleep, when you take sleep and stir it up and make it more difficult by either curtailing it or shifting your schedule, it can bring some of this stuff out more because you're disrupting the system, which is why you see it a lot in life transitions and periods of stress or traveling or people going to college. College freshmen get this stuff a lot. But one thing, when we looked at the data we looked at college students, and one of the things we showed was that actually one of the important predictors of this is not narcolepsy patients, these are just college students. But one thing that increased the likelihood of experiencing sleep-related hallucinations and sleep paralysis was actually people who reported worse mental health. So it's possible that one of the drivers of these experiences actually might not just be the sleep disruption, but actually might be the mental health disturbance, something about how, maybe something about REM regulation and something going on in the brain. I have no idea. But that seems to be something that's showing up in the literature, that people with higher depression anxiety scores are also reporting more sleep paralysis and sleep-related hallucinations. So that might actually be a part of the expression of the mental health problem as well, that some of those lines, it's breaking down some of those lines as well.
Have you got any experience? We have a question here about the relationship between sleep apnea and narcolepsy, I suppose in a context of depression.
Yeah, I mean, both. So here you have two conditions that predispose you towards depressive symptoms and extra daytime sleepiness. So yeah, I mean, I think it's unfortunate that a lot of the sleep physicians get such little training in mental health, because they don't ask. It's sort of a don't ask, don't tell a lot of the times, unless you bring it up. And then when you bring it up, they sort of don't know what to do with it. And they often hope that, well, maybe if we treat your sleep problem, your mental health issue is going to get better. So then I don't have to get in the uncomfortable position of dealing with something I don't understand. And I mean, and to some degree, that's a kind of reasonable because that's what they know how to fix. But I think that if you are one of these patients, bring it up, and you might have to, again, self-advocate a little bit for mental health. The medical system in the US has this weird line between mental health and everything else. And the people who treat everything else don't know what questions to ask about mental health, and they don't know who to refer to. And they don't know sometimes, like, actually just refer. And like, let someone else handle the mental health problem. You don't have to. Find a psychologist or psychiatrist in your health network. Let them be a helping clinician. I do this all the time. I get lots of sleep apnea patients and narcolepsy patients and other sleep disorders patients and other medical patients, cardiology patients, where they also have these mental health and sleep issues, where I get to help pick up those pieces so that the cardiologist or the sleep medicine physician doesn't have to, because that's not their job. That's not what they're good at. I'm not going to fix their cardiology problem. That's not what I'm good at. I'm not going to do CPAP because I'm not a sleep medicine physician. I'm a psychologist. I don't, in the US, we don't do that. But I do what I do, and we work together. And I think, and at least in my experience, the clinicians are grateful that someone takes this off their plate, the thing that they're bad at, that they know is important to the patient. Find a clinician that can take it off their plate. And they often just didn't think about it. They didn't think, that wasn't on their radar because they weren't used to it being. But as a patient, you can say, hey, could you get me a referral to a psychiatry or psychology? Psychiatry more for the medication, psychology for sort of behavioral therapy. And let's all work together as a team. I think that's the way forward. I think that's the way of the future. I think as everyone becomes more and more specialized, we have to work more and more as a team, because we can't all do everything.
Yeah, and the emphasis on the patient as an advocate. And of course, that's very difficult, when you're sleepy, not well, struggling with a chronic illness. And this is where we recommend take someone with you.
Yes.
Write it down. There's a lot of prep you can do before these meetings that just take the pressure off when you're in the doctor's office.
Yeah. Maybe that's also like, as an organization, as a patient advocacy organization, like, maybe that's some feedback, like, oh, maybe we should start developing some of these. Here's a sheet to hand to your provider. This is the overlap. Here's some recommendations of things here are the questions to ask, and here are the things to do.
Yeah. You need it sometimes. We all do.
Yeah.
Just in the moment, it's very hard to stay focused. Okay, I think we have time for one more. And this question, I think, gets a little bit back to that parallel presentation between depression and narcolepsy. And it is, are some symptoms of depression and some symptoms of narcolepsy actually the same symptom, with two different sources, or is it two different symptoms that are extremely similar? Good one to end on.
Yes.
That's right.
Well, and I think that when I remember being an undergraduate taking a neuroscience course, and the first day, there was a quote that was put up on the slides, and it was, when describing a very complex system, you're almost always correct in what you assert and wrong in what you deny. I forgot who the quote is, but I'll never forget the quote, because it's so true about some of these complex systems, that when you're talking about mental health, the experience of these symptoms is way downstream of whatever the causes are, the combination of a million possible combinations of causes. So is the symptom the same? Well, is feelings of guilt, whether it's a depression feeling of guilt or a narcolepsy feeling of guilt? Sometimes probably, sometimes they might be a little bit different, but I think it taken together, I think that's all, that it's almost, yeah, maybe, but the point is that it's the experience, and that it's a problem. Whether you experience guilt because of the narcolepsy, and it's not the same chemical pathway that you would be experiencing guilt as if you had a depressive disorder, either way, it's still a problem. Whatever path you took to get there, you still got there. And it's still the problem worth treating. It's not worth brushing under the rug or hoping it goes away, because a lot of these things take on a life of their own. Once they're there and take root, even after the symptoms start getting better, you get used to thinking of yourself in these terms. And so that's why I would want to say, don't hope they go away if you treat the other condition. Well, maybe hope they go away, but don't always expect that they're going to. And I guess one thing to end on, there's a concept that I'd like for everyone to sort of look up a little bit, because I think they'll find it useful. And it's the idea of cognitive distortions. And these are things that we all do. We carry around. Google cognitive distortions. It'll be a fun read. These are sort of all these things that we do that are all inherently irrational. Things like black and white thinking. Things like trying to guess the future, like forecasting. Things like mental filter, where anything bad that happens is reflective on us, but anything good that happens, well, it was just luck. Where we discount good but accept bad. Like all of these sorts of things that we do, there's a whole list of them. Psychologists, we work with these all the time with depressed people, because they're a human thing, and they are all by definition irrational. What's another good one is telling should to yourself. So whenever you say should about yourself, like I should do this, it's essentially your way of giving yourself permission to feel guilty. Because you feel guilt and you're looking for a justification of it. So you say should, and then you project it the other way. And when you say should about somebody else, it's really what you're doing is you're often looking for reasons to be resentful, because you feel resentful. And so you're looking for an explanation. But really it's irrational. People, who should do whatever, we all do the best we can. So look up cognitive distortions. And if you find yourself experiencing those, start identifying them, and you can start working with them to take that burden of that irrational thinking that leads you down this bad path away, and start working on it, or work on it with a therapist. But yeah, so that's Google cognitive distortions. It'll be fun. It'll be a fun read.
I could keep talking to you all day, honestly. And we do have a lot of other questions. I'm not sure if you can hang around and answer them.
Yeah, give me a few more minutes. I can take a couple more minutes.
I'll move you over to the typed answer.
Okay.
Thank you so much.
Oh, you're very welcome.
To have some time with you, and that was incredibly helpful. I even took notes, thinking, yep, I need to do that. Follow through.
Yeah, okay. I'll type responses to whatever's left here in the Q&A. And thank you everybody for your attention, and good luck with dealing with all this stuff we're all carrying around. So thank you.
Thank you so much.